time you have a cardiac arrest to the time this flow of this device pumps the blood around your body has to be under 60 minutes for you to have a good survival.
Yeah. I'm Dr. Louise Messara. Welcome to Season 4 of the Future Health podcast, Future Proof, a podcast about the future ways we will work, the work we will do, and the impact of technology and scientific innovation on the future of the healthcare industry. We have a fantastic lineup of guests this season as we cover topics ranging from life-saving cars to robot lawyers and even diagnostic t-shirts. So go ahead and like, share, or subscribe now so you don't miss a thing. Today on Future Proof, we're going to continue our conversation with Dr. Brian Burns about the technology that already exists, places in the world which are already leading the way, and some of the technology that's just around the corner. And we're going to hear about his plans to bring a heart-lung bypass machine to your door. I'm Louise Messara, and this is Future Proof. So we finished speaking with Dr. Brian Burns, and then we just kept talking, and we felt like there was some more to discuss. And so we're back with part 2 of reimagining the golden hour. So talk to us a little bit, Brian, about the out-of-hospital cardiac arrest space. I know this is a particular passion of yours, and I suppose in a way it's an existing application of, or an expansion of sort of technology into the trauma world.
Yeah.
Do you want to talk to us a bit about the work that you're doing there?
Yeah, so just by background, we have about 8,500 cardiac arrest deaths, or cardiac arrests occur in New South Wales every year, and survival remains at 10%. And it's remained at 10% for 40 years. So we really haven't pushed the dial in survival. And essentially for every 1 minute that goes by, you've got a 10% less chance of surviving. So you can imagine by the 10, 15 minute mark, your chance of surviving is extremely low. What we do know is if you have a witnessed cardiac arrest, so someone sees you drop on the floor, and you have good bystander CPR, and early defibrillation, your chance of survival is much better. Mm-hmm. But there's some sobering statistics from the AUSROC, which is the Australian Resuscitation Outcomes Consortium from 2019. So about 3/4 of cardiac arrests happen at home, and about 63% of them are unwitnessed. Right. And you can even have a cardiac arrest in your own house with your own family in the house, and they not know you've had one because you're up in your bedroom or in the kitchen and they're not there, and you drop to the floor unwitnessed. If you have an unwitnessed cardiac arrest, you're not getting any blood flow to your brain because you're not getting CPR.
Yeah.
And those outcomes are terrible. We also have quite a low bystander CPR rate in Australia. It's around 38%.
What do you put that down to?
I don't know. I think there's a couple of aspects to that. There's, I don't think Australians will be less willing to do CPR than any other population. It takes a concerted program which New South Wales Ambulance is working on, but there needs to be a more defined strategy around that. There needs to be cardiac arrest education in schools. There needs to be just a kind of common goal to increase CPR, basically. Yeah. And the outcomes vary across Australia. So we have a chain of survival in cardiac arrest that technology can help. So for example, if we look at the initial activation of a response, so currently we rely on someone being witnessed to have a cardiac arrest, but we talked about smartwatches earlier, and now there are watches that can tell if you've gone into cardiac arrest, and they're getting increasingly accurate, and then alert, well, first of all, talk to you and say, are you okay? You're not operating a machine that's causing it to look like that. Yeah. So to detect that you're having a cardiac arrest and then alert services. We talked about Good Sam earlier, and potentially that actual arrest on your watch could alert the nearest 5 people. We have a response time in New South Wales of paramedics of about 8 minutes in metropolitan Sydney, and that's standard across Australia. So remember I talked a minute ago about for every 1 minute that goes by, you've got a 10% less chance of survival. Mm-hmm. So you're behind the 8 ball by the time the paramedics get there. Yeah. But if they've had good bystander CPR, your chance of being defibrillated successfully is higher.
So the watch is the witness?
The watch is the witness. And the watch will ping 000, and it'll ping people through Good Sam, for example. But even more so, if you take it back a step before you have a cardiac arrest, there's a US company called iBeat Watch who are making watches that have really accurate sensors in them to detect how your perfusion, so the blood flow around your tissue, how your oxygen level and your heart rate goes during normal day-to-day life and exercise. Almost like having a behind-the-scenes stress test. And we know that patients who have coronary disease will develop abnormalities in those areas before they have a heart attack and before they have a cardiac arrest. So that kind of technology to prevent the cardiac arrest in the first place will exist, but also that technology of being able to actually prompt and alert services to get to you and people and bystanders will happen. Now, if I come on to the next thing, which is you need early defibrillation.
Yeah.
So obviously we have a lot of defibrillators around Australia now. We don't quite know where they all are. Again, an app like Good Sam, if you're a Good Sam app holder, when you go to one, you'll be able to take a photo of it. It'll get verified that it is a defib, and it'll be GPS located. And then it'll go into the app. So when you are responding, it'll tell you where the defib is. But can you imagine when you witness a cardiac arrest? It's very hard to think clearly. It might say that there's a defib in Coles, but trying to find it is quite difficult.
Yeah.
Maintaining the defibs is not legislated, and in many countries it's not. So sometimes they're kept behind a code, and you have to call a particular number and say, give me the code. So it's like an episode of Crystal Maze, for those people who remember what that show is. So it can become quite difficult. And it's expensive to keep defibs all over the place. I talked about drones earlier on for blood product delivery, but already there's work going on in when the 000 call goes, and we know it's a cardiac arrest, a drone delivering a defib to a patient. And that's particularly helpful in places that are remote, hard to get
rural.
Rural.
Yeah.
Even in Sydney, which is split by a harbour, we've got a lot of coves, a lot of difficult to access places. The ideal world I would see is your unwitnessed arrest turns into a witnessed arrest. You get bystander CPR. A drone drops a defib beside that bystander as they're doing it. They put the defib on, and hopefully that's a return of circulation and the person survives. But that technology does exist. We had a chap from Stockholm tell us about how they're doing it in Stockholm. We have issues around the drones at the moment in terms of length of flight that they can do. So in urban areas, it's pretty good. Payload is not an issue with the defib. They're quite light.
Right.
And then we have obviously civil aviation regulation, but I know CASA, the Australian Civil Aviation Authority, is quite open to discussion around how we can help the population through drone technology rather than just Uber Eats deliveries. So I think that's something that's coming.
Brian, we went offline and got into sort of different discussions around the fact that a lot of this is in the public's hands. With knowledge comes influence.
Yeah.
To some extent, we need to be, as sort of citizens and community members, engaged in what it is we want from our health services, and not be scared of the technology that we have already, and maybe think a little bit more carefully about how we're using that. We talked a little bit about the out of hospital cardiac arrests, and we talked about the watch being the witness. What's the next stage of that? What about the people that are unwitnessed, or what about the people that aren't responding?
Yeah.
Can we talk a little bit about where things are heading there? Because that's an exciting area of development as well.
Yeah, no, and I think to what you just described there can be tied up in a research trial that we're doing at the moment in Sydney that was funded by New South Wales Health, called the Evidence Cardiac Arrest Trial. So there are patients who, we talked about the chains of survival, where you get early bystander CPR, you get early defibrillation, hopefully your heart will start beating again, and early advanced life support when paramedics arrive. But sometimes that doesn't work, and sometimes the patient needs something else to get their heart back. And certainly you talked about the population and patients, and on our cardiac arrest steering committee we have a patient survivor who, he won't mind me saying who he was, but he was a former defence officer in the Australian military, and he had what's called a refractory cardiac arrest. So his heart stopped, he got bystander CPR, he got defibrillation, but the heart would not come back. Now, in a lot of settings, after about 20, 30 minutes of CPR, the paramedics will declare life extinct, because up until recently, you couldn't transport a patient with reliable CPR to hospital. So just envisage someone coming out of an apartment, trying to go down the stairs on a stretcher, and a paramedic trying to do effective CPR. Because remember, CPR is trying to pump blood to the heart, but also to the brain. And what I think the public and most of us as clinicians are interested in is a neurologically intact survivor. We're not interested, or the public aren't interested in someone to survive and go to a nursing home.
Yeah.
So this chap did get transported to hospital, but mechanical CPR allowed that to happen, because that machine goes in the chest and it pumps the chest reliably so you can bring them down the stairs. And he got into the hospital at around the 60-minute mark. So his heart was stopped for 60 minutes, but he had mechanical CPR going. And then he went into St. Vincent's, and they put him on a heart-lung bypass machine while he was in cardiac arrest. And that machine is called an ECMO device. So they put big pipes up through the vessels in your groin, and they take the blood out of your body that has no oxygen in it. They put it through a pump, and they put oxygen back in it and take the carbon dioxide out, and it pumps the blood back towards your heart and to your brain. So essentially you suspend the animation, or you suspend the fact that the heart is not beating, and you do its job of the heart and lungs while you fix the problem. And for this particular patient, his heart was in an arrhythmia or an abnormal rhythm that would not come back. And he survived. And he's now a massive patient advocate for what's called ECMO CPR. And this technology exists in Sydney. And as part of our study, we're trying to get the patients in very rapidly into hospital to go onto this device so we can fix the problem, which is either usually a blocked coronary artery or a fatal abnormal rhythm. But it's proving very challenging to get them in that golden hour. So from the time you have a cardiac arrest to the time this flow of this device pumps the blood around your body has to be under 60 minutes for you to have a good survival.
Yeah.
And that survival...
Traffic in Sydney is going to preclude you. Yeah.
And actually we did a traffic modelling paper with Emily Moylan at Sydney University, and basically showing if someone has a cardiac arrest in Sydney, how quickly can you get into one of these hospitals for ECMO? And it's extremely difficult. You have to have a cardiac arrest very close. So we are working on taking this technology, like we talked about in trauma, with various different interventions to the patient. And later this year, we are looking to do a pre-hospital ECMO CPR study where we take this.
Right, so you're taking the heart-lung bypass basically out into the community.
Yeah.
Wow, okay.
Yeah. And they're doing this in Melbourne, they're doing this in Paris, and they're doing this in London and a few other cities, Minneapolis and Albuquerque, a few other cities around the world. So it has a targeted group of patients, but these people are generally young. And if we get them onto this machine early enough, they've got survival rates of up to 40% walking out of the hospital intact, and they go back to their families, go back to their communities, and go back working. So that's something we're working on. But we're also very focused on that, trying to use technology to fix all those other chains at the moment, which is happening.
Give me an example of one of the other chains.
Well, they are things like I talked about in terms of bystander CPR, witness cardiac arrest, early defibrillation. So what I would like to see from the public, the clinicians, we advocate for things, but it'd be great to see the public advocate and, seek out, local members and ask what's happening in that space, because this affects all of us. Cardiac arrest, severe trauma, unfortunately, affects a lot of us in this country.
I've been aware of public health campaigns in other parts of the world to train the general public in CPR and the like. We don't seem to have had, I don't think we've had that in my recent memory in Australia. Some great campaigns to go online and have a look at are the Staying Alive campaign. I think that was out of the UK, was Vinnie Jones.
Vinnie Jones, the footballer.
Yeah, absolutely. And there's, I think, some other great ones out of the US. These are general campaigns to just give people basic awareness around rhythm and depth, I think, in terms of CPR, because I think the rules keep changing with CPR. So if you're not regularly working in a healthcare environment, it can feel daunting, I'm sure, to feel like you're appropriately trained to step in and help someone who's collapsed in front of you. And I think we need to increase the public's confidence in the pieces they can do while help is on its way.
Yeah, and actually one thing that just comes to mind, which we haven't touched on, is the ethnic diversity we have in Australia is quite broad. And we know that cardiac arrest, for example, is overrepresented in parts of, I'm taking Sydney as an example, where there is a higher ethnic diversity. And in some cultures, doing CPR or doing a medical treatment on a loved one or family member is not the done thing.
Right.
So there's barriers to overcome, and there's language barriers. So you can imagine a distraught, non-English speaking person trying to ring 000 and not being able to converse in their own language what's going on. And that's really problematic. And again, that's why video function will help that, because even if this person is speaking a language the dispatcher doesn't understand, the dispatcher can see, or a clinician watching the video can say, yeah, that is a cardiac arrest, and then inform them through that app function in their own language how to do CPR. And Good Sam has, I think, over 100 languages programmed into it, so you can explain to the bystander in their own language, I'm telling you now you need to do CPR and this is how you're going to do it.
Wow. That's a big advance, and you're quite right. We live in a society where we need to have all of these different tools available to us. Are there particular technology pieces that you're seeing taking a lead in a rural regional setting? I know you've had some experience working in that sort of area in terms of trauma. I know that the Central West has been at the forefront of a lot of work in their critical care advisory service and the like. There are different problems, I suppose, when we look at metropolitan issues and rural and regional, and sometimes they're exactly the same. Do you bring a sort of different lens when you're thinking about the trauma picture in both of those environments, or do you feel it's what's sort of good for the goose is good for the gander?
No, a good question. I think from my own experience, having worked out in regional New South Wales, working in the pre-hospital retrieval system where we go out to these places a lot, and now also working in, a tertiary trauma centre, you do get a good overview of the different challenges that exist, but also the assumptions that are made sometimes in the tertiary hospitals about what goes on rurally. There's often a disconnect in understanding about how there are really excellent leadership and programs going on in those rural areas. And if I think about trauma and bleeding, certainly there's one of my colleagues who's a hematologist out in Orange, Doug Lenton, who won't mind me mentioning his name, has been really leading, trying to make blood products available to these trauma patients. And we actually have some quite good innovation going on in the space in New South Wales that New South Wales Health has backed. And two of those things I'll talk about briefly. One is the retrieval transfusion protocol. I mentioned earlier that we don't carry much in the way of blood products to patients. And these blood products are essentially the currency that keep the person alive until they can get definitive surgical control of the bleeding. Doug was one of the first people to really push his blood bank and the area blood banks in making these blood products available to us at the scene of an accident. So what we're talking about here is we're on the way to a severe trauma. The control centre clinician in charge realises this is also a critically bleeding patient. And the activated chain of events that sees those blood products also make their way towards the scene of an accident, usually a trapped person. So there's a convergence towards that patient of us with skills and also the blood products. And there's one story that sticks out in my mind from a number of years ago. And this young guy is about 14, 15. He was out shooting with an adult and a few adults, some teenagers and adults that are shooting rabbits. And he put the shotgun down on a fence, and they were climbing over the fence, and the shotgun discharged and hit him from about 2 meters away. Now, you don't have to be a ballistics expert to realise that's quite a severe injury. And he had a massive hole in the back of it, in his back, and it went through his liver and up through his kidney, and he was basically bleeding to death. And he was 300 kilometres from the paediatric trauma centre. But there's a whole suite of events occurred from initial paramedics to the retrieval team to essentially an emergency room type resuscitation and a lot of blood products in flight to Westmead. So he got the equivalent of a huge transfusion in flight. We got the blood products from Bathurst Hospital. He got far more blood products in the actual operating theatre, and he made a full recovery despite severe bleeding, and he would be someone that we would call an unexpected survivor. So those kind of innovations have really helped, and they do exist. I think the added layer to that will be using drones to get them there faster and not without relying on, police and other people to bring the products there.
Well, it's an amazing story of sort of human teamwork and human ingenuity. And as you say, really with technology, all we're trying to do is continually shorten the length of time from sort of human intervention to human intervention.
Yeah.
Brian, thank you again. Thanks for agreeing to stay longer. And we look forward to watching what you create for us next. Thanks very much, Brian
Louise.
Burns.
Cheers.
Go ahead and like, share, or subscribe now so you don't miss a thing.